colleagues, it is my very great pleasure to present the next speaker, who is going to talk about a very interesting topic. Actually, it's one of the major evolutions in practicing the management of severe aortic stenosis risk that has been the change from operative risk assessment to age criterion to select who is the appropriate mode of treatment for which patient. Professor Michael Reardon from Houston Methodist Hospital at Houston, Texas, is the most appropriate person to give this talk, as he is world pioneer in the research around this field. Dr. Reardon.
Well, thank you. I want to thank the organizers for inviting me back to this meeting. It's always a great pleasure to come to Athens. And if I can get my slides up, please. So we're going to talk a little bit about how confident are we that the TAVI guidelines are really appropriate as we switch to age rather than risk. And these are kind of my conflict of interest across the TAVI field, but my biggest conflict of interest is I'm a cardiac surgeon. I like doing aortic valve surgery. I really enjoyed the first two talks. In fact, I did my first aortic valve replacement in 1983 with Denton Cooley. And in 40 years, it's really interesting to see how it's progressed. And most of the progress has come really over the last 20 years as TAVI has forced us as surgeons to do a better and better job. So if you look at the US guidelines, you saw this very briefly. US guidelines really divided into three groups. If you're 65 or less, you're going to live 20 years or more, they still recommend that you have surgery. If you're 80, you're going to live 10 years or less, they recommend, as long as you're appropriate for a transfemoral TAVR, so that means, to me, not necessarily transfemoral, but any access that doesn't put a hole in your chest, you should still have TAVR. Between 65 and 80, you look at the physiologic risk of surgery, the anatomic risk of TAVR, and the patient's wishes. The European guidelines are a little more conservative. What the European guidelines say is that if you're 75 or less and your risk STS or Euroscore 2 is 4 or less, then you should probably still have surgery as long as you're operable and really unsuitable for transcatheter TAVI. If you're 75 or older, or your STS or Euroscore 2 is above 8, then you should have TAVI instead of surgery. So a little more conservative. So what we're going to do is, I think, try to look at where we fall between these two. And in fact, at PCR, we're going to present the low-risk data from the randomized Evolute trial for patients less than 75 as one way of kind of look at this, and Tommy Modine will be presenting that. So how did we get to where we are with our current guidelines? We did it mainly through the randomized trials. And the first two randomized trials were the PARTNER 1A trial for high risk and the core valve high risk trial. In these trials, the primary endpoint was all-cause mortality. And in the PARTNER 1A, there was non-inferior all the way through 5 years. In the core valve, it was actually superior for TAVR in years 1 and 2 and non-inferior by year 5. In fact, I was so shocked, as I was the lead surgeon in core valve high risk, that we didn't beat TAVR, that I went back and looked at every death, when they occurred and why. It was really interesting that between 0 and 30 days, there was no difference in the mortality between TAVR and SAVR. And after 120 days, there was no difference. And the only difference between 30 days and 120 days where TAVR actually was superior statistically to surgery. So why would that be? Well, how do we define mortality in surgery? 30 days are in hospital. We kept all these very old, sick patients who were mean age of 84 alive, and then they went to long-term care, and they died in long-term care. But if you survived 4 months, you got better. So as you look at higher risk patients, it's this physiology and ability to recover, not so much the operative mortality that matters. Then we went to intermediate risk. Now, intermediate risk, the FDA changed the endpoints because in PARTNER 1A, there were statistically more strokes in the TAVR arm than there was in the surgery arm, and that worried everybody. And so at high risk, that primary endpoint for both trials became all-cause mortality or disabling strokes. And if you see in the PARTNER 2A trial, it was non-inferior, but the lines cross at 3 years, and they're unfortunately heading in the wrong direction. Now, we're going to get 10-year data, and it's going to be very interesting to see if this is much like Excel and other trials, where as you go from 5 to 10 years, surgery actually starts to look a little bit better. In the TAVI trial, it was non-inferior all the way through 5 years, and it really hasn't changed. So then we went to low-risk trials. In low risk, you're going to have less events, so you have to do something. You have to add patients, you have to add time, or you add events. Patients can cost more money. These were already expensive trials, and time can cost more money depending on how you do it. So Marty Leon and Michael Mack decided they'd add events, so they have a primary endpoint of all-cause mortality, all stroke, or hospitalizations. And they were statistically positive for TAVR, but a lot of this was driven by hospitalizations. Jeff Popman and I, when we ran low risk, said, well, listen, we're going to be low risk. We're going to have to convince surgeons. If you use hospitalization, surgeons may not be convinced by that, because it can be a subjective thing about who you hospitalize and who you don't. So we stayed with all-cause mortality or disabling stroke, but we used a Bayesian analysis, which lets you predict to your endpoint before you actually get to 2 years, although we've gone back and validated that with full 2-year data. And it was non-inferior. So when you look at one as superior and one non-inferior, remember, these are completely different endpoints. In fact, when I added hospitalization in, the low-risk trial for Evolut became superior too. That's one reason why Gene Brunwald, when he discussed this, said this was such amazing data for low risk. And so we got that approved. Now, there are some Kaplan-Meier curves that we can get out of the low-risk trials that I think are important for us to look at. If you look at 30 days, the TAVR mortality was 0.4% in both trials, surgery 1.1 and 1.2%. TAVR always has had an early advantage over surgery. The question has always been, is it going to last, particularly as we go to younger patients? You go to 1 year, you notice that both TAVI and surgery are lower risk in the partner trial than the lower numbers in partner trial than Evolut, and that's because they brought in a lower risk group of patients, and we can talk about that later about why we know they're lower risk. A big part of it was that over 1/3 of the patients who were deemed appropriate locally were then screened out by the National Screening Committee. If we look at stroke, stroke was statistically positive for TAVR, less stroke in TAVR than surgery, and both these trials kind of reverse of the partner 1A. And remember that the embolic protective device, the Sentinel protection device, only became commercially available in the U.S. halfway through this trial. And Marty, Leon, Mike Mack, myself, and Jeff talked about this. We decided we weren't going to allow them. We couldn't ban them, but only a few percent had embolic protection device. But even without embolic protection devices, you see the stroke rate was very low. And then you went to hospitalization. Hospitalization was statistically positive for TAVR in both trials. So we know that low risk at 1 year looks pretty good, but how does it go further on if we're going to have if we're going to change our guidelines to less than 75 or down to 65? Well, this is the 2-year partner data. You can see that the primary endpoint of all-cause mortality, all-stroke hospitalization is starting to narrow from a delta of 7.1 to a delta of 5.9. And if you look at mortality, it narrows even further, a delta of 1.5 to about 0.8. It's half the delta. And even in stroke, it's starting to narrow to about half that. Unfortunately, this is starting to look like the partner 2A data that crossed at 3 years. We should get the partner 5-year data this year, and it's going to be interesting to see. Hopefully, these don't cross like that, but they're certainly heading in the wrong direction at 2 years. We published a 2-year all-cause mortality disabling stroke from the low-risk trial, and you can see that it hasn't changed at all. The early advantage of TAVR maintains, and this is true for both mortality and for stroke. And in fact, this year, John Forrest presented our 3-year low-risk data, and this recently we published this in JACC. And what you see is the delta at 30 days, which is 1.8% in favor of TAVR, was 1.8% at 1 year. It was 2% at 2 years. It's now gone to 2.9%. So now this is the first time we've actually seen the early advantage of TAVR is actually widening with time rather than staying stable. We're going to look at the 4-year data this year. We probably won't publish that, but the 5-year data is going to be out a little bit later than the partner data. Again, we got our data on the podium at ACC when I gave this with Marty, only because we used a Bayesian analysis, so we're running a little bit behind. But certainly with this early data, it would suggest that things are moving in the right direction for TAVR, at least with the self-expanding valve. And this is true, mainly driven by mortality. Again, something that's very important is your mortality was actually better using TAVR with the self-expanding valve. Now we have some longer-term data. This is the NOTION trial, which is the Nordic trial, the Finland, Norway, Sweden trial that looked at people 70 or above. It was a very early trial with the original core valve designed as a superiority trial. And we're out to 8 years now, and you see there's no difference in all-cause mortality out to 8 years. The last person in NOTION crossed a 10-year endpoint in April, so we're going to get 10-year data pretty soon for the NOTION trial, which would be, of course, the longest follow-up we have up to date. How about less than 65? That's one of the things that we're asking about. Well, if you look at the 2 trials, in the partner trial and the Evolut trial, only 7% were less than 65 in the partner trial, and only 6% were less than 65 in the Evolut trial, and only 1.3% were less than 60. Now, I ran the screening committee for Evolut, so I can talk about that. I can't really talk about the partner because I wasn't part of that trial. But if you were less than 65, you didn't get into this trial unless you were not a normal less than 65. There was always something else going on with you. So these weren't really robust 65-year-olds. So how about how people were randomized in this trial and what was the risk level? Well, again, all these patients were seen at a local heart team which deemed that they met all the inclusion, had no exclusion, and they were anatomically appropriate for TAVR with the valve chosen and surgery. One would think that it went up to the National Screening Committee, virtually everybody would be accepted. In the partner trial, 34% of the patients were screened out at the national, 34%, a third. If you're screening out 1/3 after the local team has said, this is not an all-comers trial, and 14.8% were screened out in the Medtronic trial. So as we do this and we look at this data, remember, these are pretty highly selected people. These are not all comers. How about bioprosthetic valve dysfunction? This is David Capodanno's work from Europe, and what David has said is that bioprosthetic valve dysfunction is divided into 4 broad buckets. There's structural valve deterioration when there's something wrong with the valve itself. Non-structural, there's something wrong around the valve, thrombosis, and endocarditis. Now, there's a lot written about early failure of surgical valves. We wrote our first paper on early trifecta failures in 2017. Trifecta was then owned by St. Jude. The St. Jude people I knew very well told me I shouldn't publish my paper because they had better data. I said, well, publish your paper. We saw a lot of early failure in trifectas. Since then, both Cleveland Clinic and University of Michigan have published studies looking at over 1,000 trifectas compared to 1,000 Carpentier-Edwards, and both have shown trifectas fail early. So when we start talking about structural valve failures, you have to remember it's not just a class of valve, either bioprosthetic versus TAVR. Each valve has its own failure rate. Valve failure is valve design and tissue science. And so we can't compare surgical valve to surgical valve and think they're going to be the same. We can't compare TAVR valve to TAVR valve and think they're going to be the same. So what do we know about TAVR durability? Well, we have 5-year durability from the high-risk trials, but remember the high-risk trials were mean age of 84. We don't expect these valves to wear out in these patients' lifetime. They're going to die. We went to intermediate risk. The mean age was 81. We're still not going to learn much. And we've gone now to low risk where the mean age was 73.5 to 74. We may learn a little bit more, but that's still a relatively elderly population compared to what some of the ages are where people are putting in surgical biologic valves. And we also have some durability at 8 years from the NOTION trial, again showing really good durability of TAVR valves and surgical valves. Now, one of the things that Lars Sondergaard did was Lars went in there and said, well, most surgical trials, and there was recently at AATS a thing on the RESILIA at 7 years, use Aitken's definition. And Aitken's definition was basically saying when your valve fails and you come back to surgery, it's a failure. Well, a lot of these people just don't come back. That's a very poor definition. So most of us have gone to the VARC definition. And what VARC says is if you, from your discharge or 30-day echo to your current echo, if you have an increase of the mean gradient at 10 millimeters of mercury or more, and to have final mean gradient of 20 millimeters of mercury or more, then you have moderate structural valve dysfunction. And if it goes up by 20 and ends up at 30 or more, then it's severe. Well, what Lars found was that there was double the risk of moderate structural valve deterioration for surgery as opposed to TAVR. Again, somewhat different than what we think, because as a surgeon, I always told people you should do surgery because we have the durability data. And if you look at for severe, numerically a little lower for TAVR, but no statistical difference. So we were very interested in this, and I presented this at ACC, I don't know, 2 years ago, I guess, and published this in JAMA Cardiology. And what we wanted to do is we looked out there and said there was limited data that existed on the incidence and factors that were associated with structural valve deterioration after TAVI and surgery from large-scale, multi-center randomized trials. Now this is Pibro's work from the Partner 2A trial, which we already talked about. Partner 2A, remember, was XT, an earlier generation, randomized against surgery with a non-randomized continued access arm of S3. And XT had statistically more structural valve dysfunction than surgery. S3 was 3.9 versus 3.5, so it was no difference. This was considered a win. But if you read the paper and go back and look at when they really did some matching, in years 4 and 5, S3 actually had more structural valve deterioration than surgery. So we really wanted to go, based on some of our prior analysis, to see what was going to be the 5-year incidence, outcomes, and predictors of hemodynamic valve dysfunction in patients that had a core valve evolute versus surgery from our high-risk and intermediate-risk trials. So the way we did this, we took the high-risk and the SURTAVI randomized cohorts, and we used the randomized cohorts to compare the differences in structural valve deterioration. We then add in the non-randomized continued access, because they're not going to be the same. They never are when they're non-randomized. And we used that greater number, going now from 2,000 to 4,700 patients, to look at the clinical outcomes and the predictors of structural valve deterioration, used the definition I told you about. And we had an independent core lab, JO's Mayo Lab, and I went over this with Steve Yakubov and Kendall Grubb, and we looked at every single one of these to validate what the core lab said. And what we found is that 8 years, the structural valve deterioration rate between surgery and TAVR was statistically less in TAVR. This was really the first time this was shown. In fact, when we presented this at ACC, this was actually got more buzz than when I presented low risk or presented intermediate risk, because this really was a little unexpected and somewhat turned a discussion on its head about what had the best durability. You look at small annus defined as annus of 23 or less on CT, the difference was even wider for the self-expanding valve over surgery, and at 23 or more, it was still numerically better for TAVR, but it didn't reach statistical significance. Now, the money slide is this. If you had moderate or greater structural valve deterioration, whether you had surgery or TAVR, it doubled your risk of all-cause mortality, it doubled your risk of cardiovascular mortality, and it doubled your risk of being rehospitalized. It is not a good thing to have even moderate structural valve dysfunction. Who did not get structural valve deterioration? Men, older patients, those with atrial fibrillation and those with prior PCI. Who got it? Those with larger body surface area. Now, the converse of that is who does get it? Younger women who are healthier. Why did PCI and AFib not get structural valve deterioration? Could be the competing risk of death, or it could be their own anticoagulation. I don't have an answer for that yet, but we're looking into it. So the conclusion was if you had surgery, you're going to have a higher risk of structural valve deterioration in this randomized trial compared to the Evolut core valve. And if you got it, it was going to double your risk of dying and double your risk of being rehospitalized. Steve Yakubov then went and looked at from structural valve deterioration to all structural valve dysfunction. We did a similar analysis looking at the randomized and the non-randomized cohorts. And what Steve showed is for all structural valve dysfunction, it was statistically higher for surgery than it was in TAVR. And this was mainly driven by two things: the higher structural valve deterioration in surgery and the higher rate of patient-prosthetic mismatch in surgery. Thrombosis and endocarditis were no different. So when I look at this, I kind of do this in my age when I'm thinking about the guidelines. The orange bars here are U.S. life table analysis. I will ask you to remember that when we put in a biologic valve, unless it's a Ross procedure, you will lose life years off your life. The Ross is the only operation that keeps you on a normal survival curve. So these are normal survival curves, so you actually have to subtract a little bit to get it. And the box up here is Carpentier-Edwards, which is where the supraannular valve seems to be following, and it's our best surgical long-term data. So if you're 80, you're going to live about a little less than 10 years in the U.S. Europe is about the same, and your risk of valve deterioration that time is about 4 or 5%. That's pretty good. It's a pretty good thing. You're unlikely to need anything in your lifetime. If you do, you're only going to need one more thing. 75, you're going to live about 13 years, maybe a little less. The risk now is about 8%. Still a pretty good thing. I think the European guidelines are very conservative. Move down to 65, now you're going to live about 20 years, and the risk goes up to about 18%. And we can argue about how good that is and whether or not that's right or not, but you're still probably only going to need one lifetime thing. Now, when I choose for a lifetime valve, one thing I ask myself is, who has the best hemodynamics and the best durability, which is what you're going to live with every single day? And then I think, secondly, about coronary access and valve, because those are only theoretical things in the future. And as you heard from the biologic, the surgeons only think there's going to be a 1% chance you're going to have your coronaries done later on. So it's not a very high-risk thing. But hemodynamics and durability is something your patient lives with every single day. And we have some pretty good data that if you don't get to an EOA of at least 2 when you're younger, you cannot increase your flow without increasing your gradient. Remember, the mean EOA from Becky Hahn's work for a Evolut valve was 2.03, for an S3 valve is 1.66. And these are going to be important as we move to younger patients. It's not important if you're 80 and you're sitting on the sofa, but if you're a young 70-year-old like me who gets up every day and runs, it's going to be important. Thank you very much. I enjoyed the opportunity to talk to you.
Thank you very much, Professor Reardon.